So what are the major components of the bone, Nani? Yeah.
Like proteoglycans.
So what is the role of these different proteins?
For agility.
So what is more important for bone strength? Is it the mineral or is it the matrix?
Mineral is slightly more important, but they both contribute to bone strength.
Okay, so mineral will give you the density, but the overall strength, the geometry and other things also will come from the matrix component, which becomes important. Other than the bone mineral and bone matrix, the third important component is the cellular component. So what are the three different cells and what are their individual roles in terms of bone metabolism or bone synthesis, formation, modeling? Hmm. Hmm. Osteocyte, which is basically a mature osteoblast, which is the regulator. So one of this is the creator, one is the destroyer, and the other one is the overall sustainer. So as we discussed, the bone, the major component is the calcium hydroxyapatite, and along with that, you've got different proteins like collagen, osteocalcin, GLA protein, and a lot of water is also there. And this water gives flexibility to the bone in that regard. So around 50 to 70% is actually your calcium hydroxyapatite, and 20 to 40% is basically the matrix component, the protein component, and 5 to 10% will be the water in that regards. So now 85% of bone is in the cortical region and 15% is in the trabecular region. So from a bone health perspective, the cortical bone is more important and it's the strongest. That is why you don't have fractures typically in the mid shaft region. You have fractures more towards the joint area, so more towards the region in the trabecular region. Now you've got three major cellular components. We discussed about the destroyer, the regulator, and the creator, and these three will really interact. What is the effect of different hormones in all this system? And this will tell you the impact of deficiency or excess of those hormones and the potential role of these hormones. So growth hormone IGF-1, what is the effect on the bone? Yes. What else? There are multiple things we have listed here. What about the absorption? So basically, if you talk about growth hormone, it will increase calcium absorption, it will increase phosphorus absorption. That's why we use it in hypophosphatemic rickets. It will have an effect directly on the osteoblast. So it's mainly a bone anabolic hormone, so to speak. It is going to increase your osteoblast, osteocalcin, alkaline phosphatase, type 1 collagen, all formation markers which are there in that regards. There are also osteoblast independent effect of growth hormone directly on the bone using the IGF-1, which is going to cause increased bone in terms of bone overall. So growth hormone is good for the bone from that perspective. Now GHD, of course, you will have low bone mass. But would you underestimate or overestimate if you do it using a DEXA machine? Would the low bone mass in growth hormone deficiency be overestimated or underestimated using an aerial BMD or a two-dimensional BMD? So you will say you have stronger bones. So your bone size will be less, and if the size is less, when we talk about BMD, we'll talk about that. If the size is less, it will be said, okay, it's much lower. So you will overestimate the severity of low bone mass in GHD. Acromegaly, of course, you will have high bone mass. But when you give growth hormone in the initial phase, you will have a decrease in bone mass because of whatever effects, acute effects. But long-term effects, they will cause increase in bone mass. But studies in children with short stature using growth hormone and DEXA are confounded by the fact that growth hormone treatment increases height and it will increase the BMD. So if you look at volumetric BMD, there is an increase, but the increase is lower as compared to the conventional aerial BMD that you are seeing. Thyroxine, I said, plays an important role in terms of bone turnover. So it has an effect on bone formation using the osteoblast as well as the effect on osteoclast. So if you have thyrotoxicosis, the bone turnover is more. If your turnover is more, you will have more resorption first and then formation. So you will have this effect. Also, it has an effect on calcium, inhibits calcium absorption, and thyrotoxicosis we discussed will cause low bone mass. Hypothyroidism causes an overall low bone turnover scenario. PTH. What is the effect of PTH and which cells is PTH is mainly working on? But which cell it works on mainly? Osteoblast directly, and from osteoblast it regulates osteoclast. So it is acting in both one, but its primary action is happening in the osteoblast. Of course, it will increase calcitriol, it will increase phosphorus excretion, it will allow the calcium to go out of the bones, so that is also bad from that perspective. It has a very significant direct effect on the osteoblast. And from there, it produces a number of second messengers, including IGF-1, BP5, and IL-6. The effect on osteoclast is largely through the PTH effect. So OPG and other axes are affected from that perspective. So in hypoparathyroidism, you have a low bone turnover. And in hyperparathyroidism, you have got low bone mass, which is something which we see off in that perspective. Treatment with PTH already also have a variable response. So if you give a continuous versus a pulsatile PTH, what are the difference?
Continuous PTH formation compared to intermittent.
Okay, so when you give continuous means what? Infusion, like insulin? So do we give subcutaneous infusion or subcutaneous injections? So not the infusion. So if you give continuous PTH, like continuous infusion, you will have bone resorption. But if you give intermittent, you have got this time daily PTH that will give you a more bone formation. So as against insulin, which you need point to point, time to time regulation, you want an infusion. Here you don't want an infusion. You are happy with a intermittent daily injection. Now calcitriol, I said, has a dimorphic role. If you have got too much of vitamin D, it will activate the osteoblast. If you have got deficiency, it will stimulate basically the osteoclast to give you more calcium. It of course increases calcium absorption and phosphorus absorption both from the intestine as well as from the kidneys, and your calcium phosphorus becomes more. What about glucocorticoid? So what are the effect of glucocorticoid on the bone? Good or bad? So what are the causes of this bad effect?
It's the osteoblast. It's the calcium absorption of the gut.
What about vitamin D? What about growth hormone? So it has got, what about sex hormones? So it has an effect on everything. So cortisol is bad for bone because it has a direct inhibitory effect on the RUNX pathway and the BMP2 pathway, reducing your osteoblast activity. It has an increased effect on the rank ligand pathway, increasing bone resorption. It has a calcium loss from the gut as well as from the intestine, and that's why you will have low levels of calcium and phosphorus which will be there. Calcitonin is a very, very specific agent. Where does calcitonin act on? So mainly it is an anti-resorptive agent. We discussed when we talk about OPG. Now, if you remember OPG, we talked about estrogen, calcitonin, and the third one was bisphosphonate. So in a way, it will of course have a decrease in the rank ligand activity via the OPG, decreasing the osteoclast activity. So it's a anti-resorptive, but its effect is transient. There is a tachyphile axis which happens with calcitonin. It decreases calcium absorption and phosphorus absorption, and you will have low calcium phosphorus. Now, very interesting, which hormone is more important in male? Is it testosterone via DHT or testosterone via estrogen in bone formation?
Estrogen is the end response.
So for the bone mass also and the bone Maturation also. So skeletal maturation we discussed. What about skeletal mass? Via estrogen. So if you have androgen insensitivity syndrome, what do you expect the bone mass to be? Normal or increase? Your estrogen levels are high from that regards. And so there are a lot of studies which have been done. And if you want to really do a study of the effect of testosterone acting via DHT versus testosterone acting via estrogen in a male, what will be your model? Animal model in which you can test it out.
Yeah. Also,
So first of all, you will orchidectomy, you will remove their testes. One, you will give testosterone with aromatase inhibitors, so they are not producing estrogen, and you will see the testosterone. Second, you will give a non-aromatizable androgens like DHT, and then you will get the result. So people have found that both mechanisms play an important role. It's not just the effect of estrogen, which is there are other effects as well. So while aromatase knockout mice, treatment with aromatase inhibitors, estrogen receptor problem in males, or aromatase deficiency in males causes low bone mass, there are effects which are independent of the estrogen axis also, which are involved in cortical thickness, which is an important determinant of bone strength. So testosterone can be aromatized to produce estrogen, which of course we talked about is an important anti-resorptive agent using the MCSF pathway, increasing OPG and decreasing the osteoclast activity. It also has a positive effect on the osteoblast plus the effect of cortical thickness. So estrogen is good for the bone. There is no confusion about that. Now, whether it's the only hormone regulating in male is the question. Testosterone is also converted to DHT, and there it will act on the androgen receptor, which plays an important role in calcium absorption, phosphorus absorption, and many other mechanisms. So there is a dual role of testo using both DHT and the effect of estrogen. So now if I summarize everything about the hormonal regulation of bone, we have got growth hormone, which is predominantly a bone forming hormone, increasing the activity via the osteoblast, as well as direct growth hormone receptor and IGF-1 effect. It's a positive effect. We've got calcitriol, which insufficiency will also cause an increased activity. So it's a positive effect in that regards. Cortisol is going to inhibit the osteoblast. It is going to increase the osteoclast. So it is bad for the bone. Now, testosterone, as I said, is converting estrogen. It is going to inhibit the resorption. So it is going to be good for the bone. Estrogen will be good for the bone. What about insulin? But if you have obesity, what happens? So that is an important thing to remember. So it's just that insulin more doesn't mean it's good for the bone. That's why type 1 diabetes have a low bone mass. If you give treatment, their bone mass increases. But if you have obesity and insulin is not working, that's going to be a bad thing to be born. So PTH increases bone formation, reduces the apoptosis of osteoblast with no effect on matrix. Estradiol increases osteoblast. Calcitriol increases bone matrix. Growth hormone IGF-1 are good for everything. So these are good bone forming agents. Cortisol is bad for everything. So this is the important thing to look at. The final few words about the effect of obesity. So what do you expect the bone health in obese children? Okay, but isn't obesity has more estrogen, better bones? So the bone, first of all, is the bone mass less in obese individuals or not?
Yes.
So their bone mass is really not bad, but the bone is not strong enough to cope with the weight. So because their weight is more, so the fracture rate is more. So obese adolescents have a higher fracture rate, both for limb fractures as well as other fractures as well. So they are more important, even though their BMD may not be low. So now what happens here is that when you have adiposity, it spills beyond the skin, goes to the liver, causing insulin resistance, goes to the muscle, causing weak muscle, and then finally it's also deposited in the bone. So as I said, bone also has fat. If you got more fat, your bones will become weak. That's a very simplistic scenario. There are many other effects of leptin and other regards as well from that perspective. So now, which hormones are affected in obesity? We talk about them as a physiological change which happens. So what happens to growth hormone in obesity?
The growth hormone level will be high.
So growth hormone resistance with high growth hormone.
Sensitive state with high growth. No, low growth hormone. Sorry. Sensitive state.
So obesity is associated with low growth hormone. What happens to thyroid, TSH? Cortisol is increased. That's why pseudo Cushing's is there. So you will have low calcitriol because we know obesity, you have got this vitamin D deficiency which happens, and you have high cortisol. So now all these you talk about physiological responses. So obesity causes GHD-like picture, Cushing-like picture, but whatever has happened, you actually have a low growth hormone, you actually have a high cortisol, so your bones will become weak. So this is an important thing to remember from that regards. You've got high estradiol, which I was talking about, will actually counter-regulate. It is going to increase that. So obesity, in a nutshell, is going to compromise your bone. What about undernutrition? Okay, will be low.
Cortisol
Will be high because of stress. And importantly, although your growth hormone is high, this growth hormone is working towards the lipolytic pathway, not the growth pathway. So IGF-1 will be low, which is an important mediator. Calcitriol will be low, cortisol will be high, estrogen will be low. So while your obesity is also bad for bones, low bone mass is also a feature of malnutrition. So if you look at the curve in terms of the overall prevalence of low bone mass, it will be a J-shaped curve. Best to have a reasonable weight. Too little weight is bad. That's why we talk about so many conditions, anorexia nervosa. There you, of course, have the estrogen defect and all those things coming in. And bad obesity is also bad. So optimum level is there. And leptin is known to play an important role as a mediator.